Um, Thanks, Tina. I'll just read out the image really quick for those of you who might, if you're having a hard time seeing it. So my cellmate got pancreatic cancer. He didn't have a family. His daughter disowned him, so he gave up on himself. He wasn't eating. He stopped watching TV. The officers took him to medical. He asked to come back to the cell. He didn't want to be up there alone. So they brought him back and left him with me. His breathing became erratic. His eyes went gray. I didn't want to call the guards, but I had to. If he died in the cell, I'd be put in the hole. That's what happens when someone dies in your cell. All right, we can go to the next slide, Mariana. As we begin our session, I would like to acknowledge that the BC Centre for Palliative Care, we work with partners across the land colonially known as British Columbia. The work we do occurs in the territories of many distinct First Nations. We are grateful to all the First Nations communities who have cared for and nurtured the lands and waters around us from all time. We recognize that all of you joining us online are participating from traditional territories of other Indigenous peoples. From coast to coast to coast, I'd like to humbly acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. As our team all works remotely, I would like to acknowledge that the land on which I work, meet, and live is the unceded traditional territories of the Coast Salish people, including the territories of the Stolo, Semiahmoo, Kwantlen, Tsawwassen, and Katzie nations. I'd like to invite you, if you'd like to pop into the chat, the traditional territories that you're joining us from today. Next slide, please. So just a few quick disclosures before we get into our topic. Our ECHO sessions are in part funded by Palliative Canada and their palliative care project. We're grateful for our partnership with them. Next slide, please. And Pallium, their ECHO project is supported by a financial contribution from Health Canada. So as a disclosure, the views expressed in this presentation do not necessarily represent the views of Health Canada. Next slide, please. All right, I'm excited to get into our topic and introduce our presenter, Mariana Fisher. I had the pleasure of meeting and connecting with Mariana in the summer and to talk about doing a session for this. So I'm so happy it's finally here. Mariana is a PhD candidate at the School of Nursing at UVic, University of Victoria, and she is also a palliative nurse clinician with Fraser Health. In her clinical nursing practice, Mariana observed inequities in the way palliative care is accessed and delivered to vulnerable populations, especially individuals who experience incarceration. Mariana's personal and professional goals include advocating for healthcare rights of justice-involved people, advancing equitable palliative care, and examining social injustices within carceral spaces. Drawing on her unique skill set developed across 2 undergraduate degrees in psychology and nursing and a master's of science in nursing, Mariana aspires to reduce the disparities experienced by people who face a double burden of incarceration and life-limiting illness. With that, I'd like to hand things over to Mariana.
Thank you for those kind and warm words and for welcoming me here. I just want to draw a brief attention to this image. I wasn't trying to show that I made it first to the finish line and got a medal. We all did. But this was from early September conference in Singapore from International Corrections and Prison Association. And what it says on this medal, it's a nation beyond second chances. So Singapore runs annual, for the last 20 years, annual Yellow Ribbon Prison Run, where it opens up challenges faced by justice-involved individuals to the community and bringing community in supporting those who are reintegrating back. It was a great honor and privilege to be able to run along 5,000 other people in Singapore, including their politicians and those in charge of correctional services who are very much champions and supporters of this cause. And I definitely didn't come close to being in the first 100 even. The heat was plus 30, and I just got off the plane the day before that, and I literally thought I will die on that 10K run. In hindsight, I should have probably registered for 5, but it all ended well, and I learned a lot from it, and just wanted to share that, as we hope eventually bringing that to Canada as well. And just want to acknowledge then the topic we're going to discuss briefly today may be difficult for some, might bring some difficult emotions and feelings around personal and professional experiences that we might encounter, or even pull on some of the strings from previous trauma that we encountered. So I want us to take a minute to ground ourselves. And I also encourage you to take care of yourself when those feelings arise in whichever way is appropriate for you. If that means, turning off your camera or leaving the meeting, and taking a few deep breaths as well. So I just want us to close our eyes and straighten our shoulders and put our feet firmly on the ground and take a few deep breaths. And feel the energy travel from the bottom of our feet slowly up to our bodies, to our abdomen, to our lungs, to our faces, to the top of our head, and leave our bodies calm and relaxed. Thank you. So my hopes for today's presentation, and as just really want to underscore, as Stephanie mentioned, it's really not me talking at you, sharing, yes, what I've learned along the way in my brief doctoral journey, but also really hoping for us to have rich discussions and comments. And if you have burning questions, please either pop it in the chat or raise your hand. It's not that me presenting and you interrupting. I really hope for us to have it a discussion and very informal and fluid. But I was hoping that we would talk a little bit about how justice-involved people in BC access care when diagnosed with life-limiting illness, in particular, a small slice of my research that I was privileged to do last year within the cancer sector. And I hope for us to reflect on how palliative care for this population is relevant to our own practice in our clinical roles, and what barriers and facilitators we might encounter when serving justice-involved people.
All right, we're going to do just a quick poll. Tina, if you can pop that up. If you can just briefly rate your current knowledge level on today's topic.
Is that the pre-session poll? Sorry, the titles aren't clear.
Yeah.
Okay.
Yeah.
There we go.
All right, so a number not at all knowledgeable, and then another good chunk somewhat knowledgeable. Got lots we can learn here today. That's wonderful. None so far very knowledgeable. All right, I think we can end that one. Thanks, Tina. Yeah, it's about 50-50, somewhat knowledgeable and not at all knowledgeable. Okay, thanks, Tina. As well, if we can just, we have a list here. I know this isn't necessarily extensive, but if you can indicate what your professional discipline is on this next poll. Give you a minute to kind of go through our list here. Quite a few social workers, counselors, nurse practitioner, RNs, researcher, great, students, and a few other. Feel free, if you indicated other, to pop in the chat. Some admin, allied health, physician, great. RN and doula. Thanks, Joy. Great to have you here. Looks like a wonderful mix. Educator on dementia. Thank you, Carol.
Oh, I see end of life doula, somebody. I think it's Joy. I was always so excited about this role.
Oh, and another great. Welcome. All right, I think we can stop that there. Thanks, Tina. We can share those results. Hospice volunteer, end of life doula. Wonderful. Great to have everyone here.
Thank you for sharing. So I just wanted to also ground us in some of the information that when I discovered led me to be interested and passionate in working in this topic. And what I found out, even during my graduate school, that just by reading literature, that we have quite a bit of incarcerated people in Canada. So almost 40,000 in federal and provincial correctional facility, and in British Columbia, almost 3,000. But these numbers are really just the tip of the iceberg because they do not account for those who continue serving their sentences on the parole in the communities. What we do know from that, while we don't have those numbers, what we do know that in 2020, and again, statistics are very behind in Canada on these issues, that 39% of those who are federally incarcerated and released into the community, their age is 50 plus. And so that rapid aging that we experience around the world is also mirrored in prisons. And while we know that palliative doesn't mean aging, but poor health and comorbidities do drastically increase after the age of 75. Also, again, I've struggled to find a lot of information that, especially that's through great literature and the one that's been published in Canada, but from the small body of research that's been done by Corrections Canada, we know that 3 key factors that contributing beyond the population simply aging in prison are contributing to increase of older adults in custody, and those are longer sentences, life and undetermined sentences, and the individuals who were sentenced for historic offenses. Also, we know from the literature, especially Turner, really advanced publications in that area, that individuals' age in prison is 10 years older comparing to the same peers in the community. And we can imagine how many factors can contribute to that. Also in 2017, again, very unfresh statistics, but unfortunately those are the latest studies, that out of 721 individuals in federal prisons, 65, those were 65 and above in federal custodies, and they experience chronic diseases at a higher rate than general population, especially obesity, high blood pressures, high cholesterol, chronic pain, skin issues, type 2 diabetes, and 112 of those 721 had cancer diagnoses. Similar findings were done by the a law professor in Ontario, and confirmed also that the biggest issue is untreated chronic pain in this population. And when they asked the reasons for justice-involved individuals, why that, they said that the prescribed treatment by prison doctor were not comparable to the ones that they received in the community, or they were not able to access medication because they were too ill to go and collect them. And when we look, when the same author looked overall on how justice-involved individuals access services in the community, they found that the rate is much higher than general population, and those were particularly acute care services. So some of the barriers that exist within corrections continue for the individuals upon the release. Also, Canada has a unique colonial context, and unfortunately, that means that a lot of individuals from marginalized communities, and especially from Indigenous communities, are overrepresented in custody. So last year, I was privileged to receive a Canada Institute Health Research funding and a Health System Impact Fellowship in partnership with Michael Smith BC Research and BC Cancer. And in particular, BC Cancer wanted to know how justice-involved people in the province receive cancer care. I was supervised by wonderful mentors, Dr. Leah Lambert, who is the director of BC Cancer within the Allied Health Research and Knowledge Pod, and Dr. Kali Stajduhar. And I know some of you met her as a keynote speaker during the conference for BC Cancer for Palliative Care. So we really went in knowing nothing in British Columbian context, how those who are incarcerated and those who serve their sentences in the community or post their sentences receive and access cancer care. So questions that I asked were very broad, saying what programs and services exist, who operates them, what are the gaps, and simply just how does it happen? Because there was nothing published. So my research involved conducting environmental scan of the literature to see if there's anything been done in this area across Canada. Again, we excluded any studies that were done abroad because there's much more from the States and Europe, but unfortunately we felt that it wouldn't inform what we wanted to know, how it happens locally. And I conducted some semi-structured qualitative interviews. I ended up having 2 oncology leaders and 9 community-based clinicians who, and the inclusion criteria was the individuals who had experience of either directing or providing care to justice-involved individuals in their places of practice. So most of those were within the BC Center cancer centers. And the reason for that was because I didn't have access to go into correctional spaces to talk to folks who worked there. But within my sample, I did have community-based providers and nurses who have previously been employed by the correctional services and now work for BC Cancer. And so I want to share this rough image, and I'll go into detail about it. And the analysis is still ongoing, and it just simply because we didn't get to publishing it yet, so I'm still playing with the relationships and connections. But I'm happy to share what I've discovered so far. So the process is quite simple. There were no additional services that existed in the community or elsewhere that the justice individuals could access. When they come into correctional settings, they might not have a diagnosis previously and discovered later. They might come with established diagnosis, and they might come with diagnosis and the treatment that's been done previously in the community. When they have all 3, diagnosis and treatment, it really becomes quite straightforward for them to be able to access cancer services. Unfortunately, when they didn't have cancer prior to being admitted and discovered that they have some concerns, maybe pains that they report, this is where a lot of barriers happen because they were able, those who, for example, experienced pain that they reported, they would need to be able to describe the type of pain. They would have to have health literacy. Those who had mental health challenges had additional challenge of being able to communicate those in a way that would trigger the healthcare team to do screening and continuous assessment for this. So unless you had that previously established diagnosis, I found that it was quite an uphill battle for individual to be able to advocate for themselves and to be able to have access to doctor who would then take you seriously and say, okay, let's try to do some screening and some testing and to see. So once the diagnosis has been established, as I said, the procedure is quite straightforward. You get a referral to a BC Cancer Clinic, you're transported to the clinic, you receive your treatment. However, when we delve deeper into details, of course, to obtain that hospital referral, again, you would need the healthcare team within corrections to put that as a priority and advocate for you. Then you would need to be able to be transported, and that required to overcome some of the securities measures or things that are going on in the correctional center that day, to be able to have available transport and available correctional officers to go with the justice-involved person. Once you got to the BC Center Cancer Center, again, the nurses would meet with you and you receive your treatment. But through the details of some of the conversations of the interview, what I found is that, for example, justice-involved individuals would wear their uniforms, correctional uniforms, and they were often bright orange or bright red, which some refused to attend treatments to not be visible in the community in that way. And then those who did go had their correctional officers with them, so they were not able to have private conversations with the healthcare providers. The officers had to be there. Also, depending on your security level, sometimes you had to have your cuffs on and not able to remove them even during the treatment. So things like privacy and some of the pieces around receiving similar treatment as for general populations were lacking, not in terms of the type of treatment provided, but in terms of how that treatment was delivered. And then the biggest thing that I found, the biggest barrier was a post-treatment care, and that's why you see that squiggly line there. It's because it was never straightforward, and it was just easy to reflect that because when, and many of you might know how the cancer treatment, right? You get your radiation or you get IV therapy or you get chemo, and then you receive your instructions how to care for yourself once you go back home. And then you also need support of others to provide during that time. So for justice-involved individuals, they could not receive that communication, for example, when they're coming back for next treatment, to prevent potentially them arranging a break from prison. So they wouldn't know when their next appointment is. Also, when we think some of the measures you need, for example, maybe you need antiemetic medications, maybe you need to take your temperature every hour, etc. So some of those pieces, the nurse, of course, communicated it to the justice-involved person and the correctional officers. But once you get back to prison, for example, most provincial jails, except for one, where there's a maternity ward, do not have staff overnight, healthcare staff. So they leave at 11. So if you require that antiemetic, you might not be able to have access to it unless, again, you have relationships with those healthcare providers and they trust you, and then they might leave it with you. The same nurses, a lot of nurses express frustration. We ask them to record certain measures, either for temperature or, but they are not allowed to have a pen and a paper with them in the cell, so they're not able to do it. And of course, some of logistic measures, like you're not able to return to your cell because now you're cytotoxic and you can be exposed to your cellmate. And some of the justice-involved individuals would also struggle when they have incontinence, for example, and they're on the upper bunk, and that caused conflict with their cellmates as well. So also a lot of lack of communication between the providing care bodies. So for example, BC Cancer Centers would communicate the post-treatment care to the correctional facilities, but the correctional healthcare staff can only take orders from their own doctors. So those orders would have to be written, and sometimes they found there was a time delay. Some medications were not on provincial correctional list and allowed in those centers. And sometimes it was simply that there was nobody there to administer medication because of also huge issues with staff shortages. This is just briefly what we learned. But biggest surprising finding for me, and again, I say surprising here in a way that, no, I was not surprised that there was stigma, but I was surprised that it underpinned everything. everything I just described, from just processes and some of the simple procedures, how the care flows, that stigma underpinned every and each one of them. So when I was playing as a, novice researcher, playing with analysis and some of my findings and tried to find relationship, stigma was popping up behind every finding, behind every relationship that I was trying to discover and work with. And so it influenced diagnostic and referral in a way that if you didn't have that established and the completed paperwork with you and saying, I've been receiving cancer treatments in the past months in this center, you really had a hard time saying, oh, I have a back pain, I'm concerned about, can we assess that? And some of the practical issues that also came up are shared by nurses who work in correctional spaces. They said, well, the mattresses are so bad. Most justice-involved people have really bad back pain because those mattresses are not meant to be for people to sleep, 1 year, 2 years, and this is up to how long you can stay in provincial custody. Privacy and confidentiality was underpinned by stigma because you cannot be left alone when you attend cancer services. Your correctional officers are always there. They are more privy to your information than you do because you cannot know when you're coming back. And so there was always at most just a curtain, but of course, everybody else, heard what was discussed for your personal health matters. Flow of information, again, underpinned by stigma because there was this disconnect between the BC Cancer Centers and the correctional center. And it's simply the tensions arose from the fact that correctional centers don't have the staff, the environment, the capacity to provide that care that was required by the BC Cancer Centers. And if there was any unrest in prison or any safety situation, prisons would go into lockdown and healthcare took second place to safety priorities. As I described, post-treatment care is very complex and really depends if you have relationships with your correctional officers, if you have relationship with your healthcare staff, what your security level, how you perceive that you can be trusted with certain things. And so stigma around seeking even healthcare services because you don't want to show maybe that you have an illness and also life-limiting illness in correctional spaces because it makes you vulnerable, it makes you perceived as weak, that compromises your safety in those spaces. So for one, you might not want to disclose it for your safety. A lot of people didn't want to be seen in the community for the sake of their families who remain in the community in bright red jumpsuit, being taken with shackles to receive care. So they would choose to forego life-saving, sometimes cancer treatments because of that. And so what I found that it led to self-stigma, the stigma that's imposed on the justice-involved people, and sometimes those material elements as a jumpsuit and cuffs and correctional officers make them so vulnerable through these material signifiers. And then gatekeeping of healthcare services was probably the most shocking for me to learn. Again, huge variations exist across provincial jails. And I was surprised that some nurses who worked in them reported great team who advocates for the justice-involved people, provides a lot of support where possible, and what they called we do miracles, right? So they find ways to provide support even in those sometimes difficult spaces. But there were also teams that reported very toxic environment where the healthcare providers participated within the correctional spaces also as gatekeepers to receiving care. Even as simple as providing sleeping pills, because they would report that the justice-involved person should not feel relief from being in correctional spaces. So they felt that it's upon them to add to the punishment. And of course, judgment that, still very much prevalent, that exists in Canadian society. And it probably exists within us too. And I'll just share a personal story that I found that I had that judgment, and that was quite a revelation for me. When we were in that conference in Singapore, we were able to attend correctional spaces, visit a prison called Changi Prison Complex. And I went to maximum security prison there. And, I'm trying to do research and improve end-of-life outcomes for justice-involved individuals. And I was so honored and humbled to be there. And then in conversations with one of correctional officers, he said, "Oh, we have 2 kitchens, and justice-involved people cook food for us and for themselves. So within this space, in the maximum prison security, they cook food for the entire complex." And I said, "Oh, so justice-involved people cook food for correctional officers." And when I even said that, that didn't still come to my mind that I was being judgmental. But the response from the officer really made me feel that. He said, "Yes." And I said, "You're not concerned around that?" And he said, "No, they're just people." And that it really hit me, that realization that I had that judgment within me without even knowing it. And I think it stands out in some of the quotes that I discovered within my research, and I'll read them to you. One person said, "But I think in that moment," so when the person was brought into BC Cancer Center, "it's like, no, they're a person, they're human, like I am a person and I'm a human, and we're just going to start with that." And someone said, "The attitude is huge. I think it's one of the biggest barriers they have in getting care is overcoming healthcare attitudes and correctional attitudes and society's attitudes, and just that you are undeserving in the same way as general population. And that's the big thing to overcome." And then one said, "I think a lot of the barriers are artificial barriers that we as society have set up and we as individuals have set up." And I think it just speaks a lot to that stigma being there, lurking around the corners of every process that involves them getting cancer care in this particular. So we're ready for our breakout rooms to discuss how palliative care for justice-involved people is relevant to our own practice.
All right, looks like everyone's on their way back here. Thanks so much, everyone. We do want to make sure we have time for any questions for Mariana today, but just wanted to offer a minute or two if anyone would like to share maybe an insight that came out of your discussion today or something new that was highlighted to you as you were discussing in your groups. Feel free to raise your hand or maybe pop it in the chat.
One thing that our group came up with was more of a question, and maybe this is something that Mariana hasn't touched on yet, but just the access to palliative care inside the prison where they may not be actively seeking treatment or chemo, radiation, et cetera, outside of the facility, but wanting to have symptom management at the end of life. And what does that look like? What's available for people who are not leaving the prison to have palliative care at the end of life? Are palliative physicians able to consult the staff in the prison system to help with symptom management or achieve the goals of care of the client, or is that even something that's addressed? That was just one question mark we had.
Thank you, Joy. I'll keep it and I'll answer it once we go to Q&A.
I see a comment in the chat. Just our group had little experience with this population. Yeah, thanks for sharing.
Hi there. I know in my experience with some individuals in federal prison, they had difficulty accessing certain types of controlled substances for pain and things like that. So that was quite a big ethical concern for people who were needing pain control but couldn't access certain kinds because of the location that they were in.
Thank you for sharing, Sandra.
All right, thanks everyone. So Mariana, I'll let you continue on with your last few slides here.
Yeah. Well, I'll answer Joy's question, and not from what within my research, but in writing my dissertation proposal and reading a lot of literature, as limited as it is in Canadian context. What I learned is that, first of all, huge variation exists between the federally incarcerated justice-involved people and provincially. So for federally, we really at this point don't know much what happens, but there are different policies and legislations that guide the provision of palliative care within those spaces. And also within the even federally incarcerated people, the great variations within the prisons exist. So some prison might have improved facilities and access and wings, or they call palliative wings, and some might not. But then provincially, initially when I was asking questions, some of the leaders in the province who work in those spaces, they felt the justice-involved people stay such a short term in provincial prisons that we don't deal with those cases a lot, and those cases might happen very rare. But what I also learned from some literature that, and from my research too, that again, huge variations in terms of what's available in your particular prison, and also on those healthcare teams, they all would, act very differently, and what access they had to physicians. Some were able to come in person, some were only virtual, etc. So again, there's nothing, as a rule, as a requirement. And what also was found that it's not really up to justice-involved person if they want to stay or they go. It depends. If their care cannot be managed, they would be moved to a hospital and spend and receive care there, or even spend their final days there. And also there's a federal prison in Abbotsford that has actually palliative facilities on site, one of the very few in Canada, because it's mostly states who practice have in-prison hospices. And again, another topic around the merits of it. Some scholars argue we should not normalize deaths within corrections, and some argue, well, it's better to have access than not to have it at all. And then it's also that peer volunteers provide that care, and it improves. It serves as almost a rehabilitation tool, which also some others say that puts a burden, and we use a cheap labor of prisoners to run these hospices. So there's lots of discourse around that. But to generally answer, it really depends. It depends what facility you're in, who's advocating there for you. Do you have maybe family on the outside that can support and maybe use John Howard Society to support that advocacy, and what's available in the community? Because sometimes the healthcare team within correctional spaces can be very proactive in advocating, getting this person to, especially if they are low security risk and they're aging and they're dying imminently, and they're able to access services in the community, but community would refuse or say, I have no spaces, so we don't have the capacity to care for that individual. So right now it just really depends.
I see Carol.
Yeah, just to add to that, in Toronto, they are CSC Correction Services are coordinating with a Catholic palliative hospice in Toronto that has actually been set up for homeless, and so they're using it for individuals that are incarcerated in federal institutions as well. They're testing it out, and I think they've had their 2 now that have been allowed to come there, and yeah, so at least they're starting to have some conversation on that.
Yeah, thank you, Carol. And I'll add to this because you just sprung. I remember reading there's a gentleman who I believe is a chaplain, and he opened his own private home that brings in those justice-involved individuals who are released into community but have no families, and in the last months of their life, and he has 10 beds and runs that facility. I also had a couple years ago a director of one of the private homes for like a transitional housing for justice involved people, saying that federal corrections are tasking us with accept more and more ill, dying individuals, but we don't know how to build them, how to care. Do you have any framework around that? And I said, just wait, I'm just starting my program. We'll get there. But so it seems there is recognition that a lot of people aging very ill and have facing life-limiting illnesses within correctional spaces, and even when they're released in the community, whether it's on a parole or finished serving their sentence and have no families, there's really a big struggle of finding them places and resources and supports needed. And I think that's why this topic is so important right now for us to all recognize. And I know in the previous slide was that, reflect how it's relevant to your own practice. And, we might be a nurse who works in the hospital. I think we probably, very rarely might see a justice involved person brought in. But I just want to encourage you to think that, those folks who finish their serving sentences and are in the community, they're still justice involved. That's why I'm using this term to capture the experiences, not just those inside or in the parole, but those who already lived through that experience. And we might not know, but might see them in our care. And, what does that mean? How can we provide that trauma-informed care and be supportive and reduce some of the stigma and judgment? But also families of justice involved person, as I am myself learning right now from research, is their children and their families, they also consider justice involved people because they experience the trauma and the stigma that comes with having your parent or your close loved one incarcerated.
Got a few more minutes if there's any other questions, maybe any comments. Mariana, I know we only have a few minutes left, but I'd love to hear where do you see yourself going next with your research? Where would you like to go? I know there's so many different avenues we could kind of look at in terms of, how can we break down some of these barriers and walls with all the processes and the stigma that's at every level of that? Where would you like to kind of see things go next with the work that you're doing?
So practically, I'm going next into now my dissertation research that will look and ask similar questions to those that I was able to ask, and get into this role as a researcher, and now build on that and ask similar question around specifically palliative care within some of those centers, downtown East Side and John Howard Society, as they actively serve that community in Vancouver here. And to better understand beyond just the cancer spectrum, but for everybody who's experiencing a life-limiting illness. And then, honestly, coming out of my PhD, I never see myself doing anything else but staying within these issues that are so very close to my heart and that I'm passionate about, as I discovered that we in Canada not as proactive as I would like us to be, and justice involved people are a bit of forgotten population. So I'm gonna do anything I can as a researcher, as a clinical practitioner within my palliative nurse practice to bring attention to those issues. And as I always say, when my friends ask me, I say, if one justice involved person can die with dignity and comfortable, I'm okay. That's all I need. Just one person.
Thanks for sharing, Mariana. While if there's any more questions, feel free to take a moment to pop that in the chat or raise your hand. We do have, I think it's actually just one more question we have here. We don't have the second question on a poll, but just out of curiosity, if your knowledge level on this topic has changed, we hope that it has. And I know for me, it sure has. So yeah, we'll hear a lot, some That's great to see. All right, thanks so much. Just as we're ending here today, we will have a summary document with some of our discussion that came out of today, some of the main points of Mariana's presentation that will come in an email within a week's time, as well as a link to recording. So you're welcome to share that follow-up email with any of your colleagues. Feel free to share that, as I know we really do want to get this topic and information out there. When you leave the Zoom meeting, there will be a survey that pops up. We would love your feedback and to see if you can indicate interest on there in the last question, if you'd like more of these types of conversations. I know Mariana has a lot she could share, and others that I know she could bring on board to talk about this particular topic. And we're excited as a center to support this work. So if you would like to hear more, we would love to hear from you on that. So take care, everyone. And if you do have any final questions, feel free to stay on for another minute or so, but we'll let those of you who have other things to get to move on. Thank you so much.